Hi, everyone. We have, I think it's right about 12:45, 12:46, so we'll get started. My name is Priya Kumthekar. I'm a neuro-oncologist at Northwestern, and I'm joined by Dr. Brenner and Dr. Yang. And together we're going to just go through a little bit of the background data on rhenium obisbemeda, as well as some of the diagnostic tools that we use, and then we will leave plenty of allotted time for questions and conversation. I'm glad we have a nice intimate group here. Feel free to ask questions at any point. And yeah, thanks for coming.
Thank you. I'll start the conversation here. Here we go. So I'm just going to give a little bit of background in terms of radiation therapy and the treatment of leptomeningeal metastases first to start the conversation, and Dr. Brenner will take over specifically on the treatment that will be discussed today. These are my disclosures. So radiation therapy has long served as a pillar in the management of leptomeningeal metastases, as many of us here know. And for patients with select primary CNS malignancies, craniospinal radiation has always been considered a standard of care for patients with known risk of leptomeningeal dissemination, with the goal of disease control and cure. Some of these patients include medulloblastoma, intracranial spinal ependymoma, and CNS germ cell tumors. However, for solid tumor leptomeningeal metastases, again, there's a very important role for radiation therapy. But overall, this treatment has been palliative in nature, and it has a role for both what we call good risk and poor risk leptomeningeal metastasis patients. In terms of involved field radiotherapy, and this is the most common form of radiation therapy for solid tumor leptomeningeal metastases, such as whole brain radiation, focal spine radiation, and skull-based radiation for symptom management. It is, again, used in both risk groups, and the treatment sites are often dictated by radiographic and clinical findings on patients to decide where we treat. However, it doesn't seem to improve overall survival, as we're only partially addressing the CNS compartment. This is a graph from a published paper in 2019. As you can see that these patients all receive involved field radiotherapy, and there hasn't been a significant movement in terms of treatment outcome. So, as I mentioned, involved field radiotherapy, very important for symptom and local disease management. Again, it does not treat the entire CNS axis, so therefore it doesn't improve survival and does not control the disease entire CNS axis. It is, however, very safe and very effective. On the other hand, craniospinal radiation can potentially stop the leptomeningeal disease progression along the entire axis and potentially improve survival. The question becomes, how do we treat the entire compartment safely? So we can get some of this information from our experience in patients with medulloblastoma. There's been 2 published studies looking at comparing proton and conformal 3D conformal photon CSI. And what we found is that proton radiation has significantly less toxicity in terms of GI and hematologic toxicity, and not surprisingly, but I will emphasize this is 3D conformal radiotherapy is a more outdated way in some ways of delivering CSI. However, people have adapted this in solid tumor leptomeningeal metastases as well, again, using 3D conformal, not the modern, VMAT or IMRT photon CSI. And what they found is that most patients have a lot of high-grade toxicities and are unable to complete their treatment. So this brings in the question of using proton, and as we know, proton therapy has a limited defined range of distance that it travels. So when we use proton, it will, specifically for the spine, it can treat the thecal sac and spare the anterior organs from any radiation, including the majority of the vertebral column, and therefore preventing quite a bit of GI as well as hematologic toxicity. And this is actually very, very important in the population that we're taking care of, because these patients tend to be heavily pretreated and need to get back on systemic therapy quickly. And by not compromising their bone marrow, we are able to get them back on treatment. So back in 2018, we started a phase 1 trial using proton craniospinal radiation to treat the entire CNS axis at MSKCC. And this really just stemmed from, at the time, Dr. DeAngelis and I shared one patient, a young woman with breast cancer with leptomeningeal metastases, which I treated the whole brain, but the next week she developed cauda equina syndrome, so I had to treat the cauda equina. And then the next week she developed T-spine symptoms, so I had to treat the T-spine. So we just decided there has to be a better way of helping these patients. So we started this trial. We enrolled 21 patients in a phase 1 trial, and what we found was not surprisingly consistent with the prior published data. Proton is resulted in significantly less toxicity when we treat the entire compartment. And what we also found was a very promising median overall survival and progression-free survival. And this has led to the now published phase 2 trial comparing proton craniospinal radiation and standard of care involved field radiotherapy. And this was a randomized trial for non-small cell lung cancer and breast cancer patients in a 2-to-1 fashion. The dose was 3 grade times 10. We did have an exploratory arm of patients with other solid tumor histology, and they all received proton craniospinal radiation. This is just the patients that were included on the trial, just to show that they were well balanced. The majority of patients were female with non-small cell lung cancer, with active systemic disease. The great majority of patients had newly diagnosed leptomeningeal metastases, and the majority of patients had active brain metastases at the same time. And this was just presented at our SNO conference this year. This is the final analysis of our phase 2 trial. Still consistent to what we found in our interim analysis that's published. We saw a CNS progression-free survival advantage treating the entire compartment with proton craniospinal radiation, and this translated in more than double survival in our patients on this study. And this was just actually presented yesterday from MD Anderson. Since the publication from of the phase 2 trial, MD Anderson has also started doing proton craniospinal radiation for these patients. And this is their 45 patient analysis with the majority of patients having breast cancer. And what they found was the median overall survival of 13.7 months and median progression-free survival of 6.5 months. They also found a histology dependence in terms of survival outcome. For breast cancer patient and lung cancer patient, the survival are quite extended. For all other histologies, the survivals were short. I want to touch a little bit on circulating tumor cells. So I mentioned that histology may play a role here. What we also found from our prior studies is that circulating tumor cells is not only a great tool for diagnostic as well as response assessment, it is also prognosticative outcome. So we went back and looked at 58 patients who were treated with proton CSI in 2018 and 2020, which we had baseline circulating tumor cell data, and at least one time point afterward. What we found was that patients with low circulating tumor cell had significantly long overall survival after proton craniospinal radiation, with the median overall survival was 17 months, which was really incredible for this patient population. However, on the other hand, for a patient with very high circulating tumor cells at baseline and with minimum decrease after proton craniospinal radiation, their survival is really short. The median overall survival in this group is only 5 months, actually very similar to the involved field radiotherapy data. So this can potentially help us and guide us in terms of how do we select patients for proton craniospinal radiation. Along the same line, we also look at CSF circulating tumor cells in our phase 2 trial. And what we found was that for patients who received proton craniospinal radiation, their CSF CTC decreased. However, for those who receive involved field radiotherapy, their CSF CTC increased. So again, demonstrating that you have to treat the whole compartment in order to adequately address the disease that's circulating in the entire space. This is an example of a patient that was treated by Dr. Kumthekar. He's not in the room, but at Miami Cancer Institute, and very, very significant response 8 weeks after proton craniospinal radiation, both radiographically and in terms of CTC. And we use and we also had looked at CNSide in terms of the prognostic value, and it's consistent with what we found at MSKCC. So in terms of modern CSI delivery technique, I have highlighted a few outcomes, and what we found was that, again, to have durable disease control and survival, addressing the entire CNS compartment is needed, either through proton craniospinal radiation or the more sophisticated photon radiation, such as vertebral body sparing VMAT CSI. And this is sort of the evolution of what radiation oncology is going through in terms of how do we incorporate a more comprehensive treatment for our patient, and how do we select this treatment for our patient. Again, involved field radiotherapy, such as whole brain and focal spine radiation, still has a very, very important role in our day-to-day. But we do also realize that for CNS disease control, this is not going to be adequate. And to be able to provide safely CNS disease control in terms of craniospinal radiation, sophisticated techniques such as involved field radiotherapy or proton craniospinal radiation is needed. So in conclusion, again, radiation therapy has a critical role in the management of leptomeningeal metastases. For focal symptoms and local CNS disease management, involved field radiotherapy, again, whole brain or focal spine, continue to be an important treatment for all patients. However, if we want to achieve CNS and CSF disease control, radiation to the entire CNS compartment is needed. And for external beam radiation, which I've talked about just now, that requires proton and potentially vertebral body sparing VMAT photon to really adequately treat the space and to reduce and avoid radiation doses to the bone marrow and anterior organs. So again, in this patient population, it's so important so we can get them back on systemic therapy. Other forms of radiation technique, such as what you will hear from Dr. Brenner, in terms of rhenium, should be investigated because it is a way of applying radiation therapy to the entire CNS compartment. And lastly, circulating tumor cell in the CSF is a really important diagnostic and treatment response tool for us and should be incorporated in the management of these patients. Thank you.
Thanks, Jonathan. So I'm going to be discussing rhenium abisbamida for treatment of leptomeningeal metastases. Rhenium abisbamida is a liposomally encapsulated radiotherapeutic. Basically, the radioisotope we use is rhenium-186, and we use a chelator BMEDA, which is able to render the isotope lipophilic, so it gets trapped within the liposomes, and once it enters the liposomes, it is protonated, so it is no longer able to leave the liposomes, resulting in very high density of radiation within liposomes. The liposomes themselves exert control over the radioisotope. If you see on the top right there, that if you inject rhenium or the chelated rhenium BMEDA, it rapidly redistributes from tissues. So it's not enough to just treat with radioisotopes. You need something to confer control on it so it can stay in the target area. And on top of that, the liposomes also help in distribution. If you see on the bottom there, on the bottom right there, we get pinpoint localization of the isotope if we inject it directly into tissue. But once you put it into the much larger liposomes, which are about 100 nanometers and small by our scale, but compared to the isotope itself is ginormous, it adds in better distribution through the tissues. We use rhenium-186 because of a number of different characteristics of it. Number one, 1 out of every 10 decays is associated with the gamma. That's a non-therapeutic energy gamma, but it is sufficient to be detected on imaging. So for the nuclear medicine docs, it's very similar to do technetium imaging, which they're very familiar with. And basically, they can use the same protocols as they do for TEC scans. It has a treatment depth of about 2 millimeters, so it allows us to treat only the areas we administer it and not have outside normal tissue toxicity. has ideal energy and a half-life that works very well in terms of both treatment as well as the logistics of dealing with radioisotopes of 90 hours. And then because of the chemistry, we can load very high amounts into the liposome, so we get very high specific activity. Once we have the liposomally encapsulated rhenium, we are able to use conventional techniques to administer it. In the case of leptomeningeal disease, it can go through a standard Ommaya reservoir directly into the ventricle and then be redistributed by the CSF flow, where it is retained in the leptomeningeal space. And then for GBM, which is the other indication that it's being developed, it can be administered by convection-enhanced delivery. The net goal is to increase the therapeutic window where we have very, very high doses to the intended target space of the neoplasm, but a very minimal systemic exposure, and so high doses with minimal systemic toxicity. And then again, in terms of imaging, whether it's by convection or by a direct injection in the ventricle, easily imaged, which allows us to see where it's going as well as to do dosimetry and easily determine how much is given and retained within the tissues. In this case here for GBM, this is the first indication that rhenium bismuthida was tested in. And in this case, in silico planning on the left there, followed by catheter placement. Patients awake for convection, with the catheter being a subacute catheter that can stay in for up to 3 or 4 days. And then actually administration you see there with one of our patients where we get a good coverage over the target. The isodose lines are very tight because of the 2 millimeter path length. We get a lot where we put it, and then the remaining surrounding normal tissue is spared. In cohort 6, we administered up to 22.3 millicuries in 8.8 mLs, and that was a recommended phase 2 dose. And the survival with absorbed doses that we saw were much higher than what you expect with the external beam, where in GBM we saw absorbed doses above 300 gray, so about tenfold what you would expect with external beam in the recurrent setting, and the safety was excellent. And again, just showing where you put rhenium bismuthida, that's where it stays. You can see the top there, the area of absorbed dose with the catheters kind of hanging out there, and then the catheters are removed before 72 hours. A little bit of activity in the bowel at about 182 hours, but really nothing clinically significant. And that translated in GBM to what looks like an improved survival over historical control, where especially in the patients who had absorbed doses above 100 gray, had a survival approaching around 17 months. And we saw that it was very dependent upon the absorbed dose as well as the percent coverage of the tumor survival. In terms of leptomeninges, I think you all know the anatomy of leptomeninges, but the only prior approved therapeutic specifically for leptomeningeal malignancies was Depocyte, which is a liposomal cytarabine. Again, liposomal encapsulation allowed control of the cytarabine, such that it was retained in the CSF, allowed for improved outcomes in patients with hematologic leptomeningeal metastases. And so we, obviously, based on the path length and the characteristics, we felt that this was meaningful for potentially leptomeningeal disease. Again, the path length, 2 millimeters, you can see that when you administer it, and if it stays in the CSF, it will be able to treat the entire CSF space as well as the cortical surface of the brain, but does not have enough path length to interact with the white matter where the active division is, and so you would not have white matter injury that would be associated with external beam radiation. In our preclinical models where we administered rhenium nanoliposomes to non-tumor bearing rats, we could give up to 1 millicurie, a little over 1 millicurie directly into the ventricle of these animals, and really didn't see anything significant in terms of toxicity. They had a little bit of weight loss for a couple days, but they rapidly regained that weight. And the absorbed doses with the 1 millicurie into a small CSF space in a rat is basically over 1,000 gray. So no significant toxicity with over 1,000 gray of absorbed dose. And we saw efficacy in terms of our animals, both in a C6 and an MDA-MB231 model, suggesting that this has potential efficacy as well. So with that, we went forward to do a phase 1 single administration dose escalation trial for patients with leptomeningeal metastases, standard 3+3 design. with the primary objective of determining the safety and tolerability of it. Patients received it directly through intraventricular injection via an Ommaya reservoir, with the secondary objectives of overall response, duration of response, PFS, and OS. And we also wanted to analyze the impact on circulating tumor cells. We have completed cohort 5 as of now. We have continued to dose escalate, but we have modified it to a much smaller escalation for cohort 6, and this will probably be our final cohort, where we're now at 75 millicuries. Again, in terms of treatment planning, we just require a CSF flow study prior to the administration to make sure that there's adequate flow. And if there's adequate flow, then patients have a single 5-minute injection through the Ommaya reservoir, and then they're done. The only thing after that is imaging. And again, in terms of safety, we've had 33 enrolled, 7 screen failures, 26 on intent to treat analysis, 20 were evaluable for DLT assessment. And we've already treated the first patient in cohort 6 at 75 millicuries, and we should be enrolling our next 2 here in the next week or 2. In terms of adverse events, the most common AEs were headache, vomiting, and nausea. Most AEs were mild. We had most of them unrelated, and we had 2 AEs that were deemed definitely related. One was headache related to study drug and resolved relatively quickly. In terms of SAEs, there were 3 SARs. There was only 1 DLT, which was thrombocytopenia, and in that particular case, the thrombocytopenia correlated with the absorbed dose to the blood. The absorbed dose to the blood is known to be a surrogate for bone marrow dose with radiopharmaceuticals, and I'll show you the dosimetry data there, but it did make sense that we saw a DLT in that patient with about 2 to 3 gray dose in their blood. Again, here's the AE table, mostly mild with the exception of the grade 3 thrombocytopenia that was deemed a DLT. I showed this a little bit before, but if you look in the top left there, that is the 3D imaging, SPECT-CT, after administration directly into the ventricle at the end of infusion. It's sitting there right in the lateral ventricle with minimal distribution anywhere. And then if you look 24 hours later, you'll see that it is fully redistributed. It has left the ventricle, no significant absorbed dose in the ventricle, but it just stays along the cranial and spinal subarachnoid space. And it stays there for, we've imaged out to 7 days, and it does not further redistribute. It stays there and continues to decay. In terms of absorbed doses, this shows by cohort. Starting with the first cohort, we're already seeing absorbed doses, the cranial subarachnoid space of 28 gray, which is very similar to what's used with external beam. But by cohort 5, we got up to 250 gray to the cranial subarachnoid space, about 150 gray to the spinal subarachnoid space. If you look at the axis on the organ doses below, you'll see that's a very different axis down in the single digits. And we had no significant blood exposure through cohort 3. But then in cohort 4 and cohort 5, where we see the DLT with thrombocytopenia, we're starting to get up into the 1 to 2 gray, and one patient had as high as 3 gray. And so that's probably where we're going to be hitting our maximum tolerable dose, really not because of CNS toxicity, but because of the small amount of drug that actually leaves and is absorbed by the bone marrow. In terms of response, we had a number of patients that were evaluable by clinical imaging and CTCs. From an imaging standpoint, we saw 5 investigator-determined responses out of 16 evaluable patients, so a little over a 30% response rate, right about 30% response rate. And then another 7, this is only through 4 months, because again, this is single dose, not continuing dose. And at 4 months, another 7 had stable disease for 12 out of 16, or 75%, that showed clinical benefit based on imaging. Clinical, we had 2 responses with clear neurologic improvement, and then 10 patients who had stability of their neurologic symptoms out of a total of 14 evaluable patients. And the CTC data I'll show you in a moment, but the majority of patients had some decrease in their CTC counts. This is the survival for the group as a whole. Patients in orange are breast cancer patients. Patients in black are lung cancer patients, and patients in gray are other types of malignancies. And if they're hashed, then the patients are still alive. And if they're solid, the patient is expired. You can see the median overall survival historically for patients in the bottom there, basically 4 to 6 months. And then with the median overall survival for this group of patients, which a number of these patients are still alive, was 9 months median, with 3 patients there with the triangles receiving multiple additional doses as compassionate use, where the patients had either clinical improvement followed by progression, or clear progression by CSF or imaging, and then requested an additional dose. For those 2 patients that had clinical progression after initial response, they had clinical improvement again after a subsequent compassionate use dose. And this is the Kaplan-Meier curve. Still a significant tail there. While we have a number of patients that are still alive, we'll have to see how this curve marches out. This is the CTC response. This is best response at any time point for these patients. Majority of patients had a reduction in their CTC burden. And so the conclusions, a single DLT noted through thus far, and that occurred at 66 millicuries, with administered dose corresponding to about 250 gray, but about 2 to 3 gray in the blood, resulting in thrombocytopenia. Again, average absorbed dose is greater than 250 gray to the cranial leptomeninges. Radiographically, 5 of 16 responses, 12 of 16 stable or better at 4 months. Clinically, 2 of 14 with neurologic improvement, and 12 of 14 stable or better. MeNOS we discussed, and we're currently in cohort 6. We imagine cohort 4 will probably be our recommended phase 2 dose. Why? Because we're getting good doses, and we do not want to interfere with systemic therapy. So we feel like that probably is going to be the best dose for repeated dosing. As a single dose, that's what we're going to explore. And then we're also have a multi-dose study where we're going to be giving 3 consecutive doses at varying intervals. That should be opening within the next month or 2. And hopefully we'll be able to now extend this out to multiple doses. And then finally, the CNSide assay in terms of CTCs appears to have the greatest sensitivity for detecting response. And with that, I'll pass it on to Dr. Kumthekar.
Thanks, Andrew. So this really kind of segues nicely into talking about the response in leptomeningeal disease. One thing that we found really important in this study was to understand from a biologic level how cell and cell count in the cerebrospinal fluid are being impacted, because we all know that there are many shortcomings to our standard of care diagnostics, like cytology, imaging, and even clinical assessment. So I'm going to give this is a tiny bit of a tangent, but very much related, right? Because it's coming off the heels of really having to see what the CTC change was that Dr. Brenner kind of outlined on those few slides. But this platform, CNSide, we push forward, and I'll go back for a sec just to kind of give you guys the full name, but we are going to be basically evaluating leptomeningeal disease in a different way moving forward. And so we're looking at novel diagnostics in the CSF, particularly the CNSide platform. So we performed a clinical utility study called the 4C study. And so that timeline actually kind of spans over the past year and a half-ish. It started with a different company that then had to close for financial reasons, and then was taken up by Plus Therapeutics. So we were able to finish as much of the study as we could. Interestingly, just to kind of illustrate the need for a diagnostic like this, we opened this study in the spring of 2023 at a few different sites, hoping that we'd finish an accrual of about 50 patients in a year. We finished it in a matter of months in terms of getting those patients on, because I think many people in this room also understand we are really desperately in need for better diagnostics in the CSF, and patients were very excited to have improved diagnostics, despite the fact that this wasn't changing the treatment they received at all. The study did close, and at first the trial data was not accessible, again, because of logistics here that I just want to be really transparent about. But we really do think that this is important data to get out to the scientific field. So we have pulled together what we have with the full accrued patients, Again, not as longitudinally far out as we want, but definitely with our full cohort set, and that's what I'm going to show you today. So just one slider about the CNSide CSF diagnostic platform. It's a really unique platform where, I don't know if I have a pointer here, but this is an ambient tube that basically it's a collection tube, just the normal size of CSF collection tube. We collect it in the clinic, send it ambiently for central testing. It can stay the whole cellularly. It's basically like a really concentrated Streck tube for those of you who are familiar. And it can keep cells intact for at least 4 days, probably longer, but at least that long. So enough to get the tube back to where it needs to be for central testing. And then from there, once that specimen arrives, it goes down 2 different workflow pathways. One that is basically looking at tumor cell detection, so basically your CTCs, your cerebrospinal fluid, whole cells. And then we also push it through cell-free DNA and also basically get next generation sequencing on the CSF. So the study design was this. Basically, we did at concurrent time points, we looked at all the standard of care diagnostics that we all use in our clinic, so imaging, clinical evaluation, and cytology. And at that same time point, we also obtained CNSide testing. So this is just depicted here, time point 1, time point 2, baseline, and so forth, right? And the goal originally with the study was, of course, to see patients through the length of their care. We got as far out as we can, and we're going to, again, present that much of the data today. And our goals here were basically to understand, is there a tumor? Is there leptomeningeal disease? Because we know this can be hard to diagnose. We want to know, is there a target? Do we have other therapeutics that we might be able to use for these patients based on things like FISH and NGS testing? And really importantly, is there a trend? I know I struggle with this in the clinic. Do I keep a patient on a therapeutic? Am I seeing response? Am I seeing stability? Can I even base that on imaging, clinical evaluation? It's very difficult. So these are the 3 goals that we had that we wanted to achieve via serial monitoring of CSF tumor cells, ctDNA, and again, juxtapose that with our current standard of care diagnostics. So the primary endpoint of the study might seem unique to many of you all. It was basically to understand, again, clinical utility. What does that mean? We need to understand, is this test useful? I know that we all probably could think that we can answer this without scientific basis. Of course, yes, it's going to be useful, but we need to show in a scientific fashion that it's useful. And the reason we need to do this is because this is how we get reimbursement for our patients, right? This is a huge part of that process. So whenever we're thinking about developing these testing, we need to think about analytic validation, clinical validation, and clinical utility. So this was, the first 2 steps had been done. This is really showing the regulatory bodies that be, the third-party payers that be, that we really have utility for this. It impacts us as physicians on how we treat and manage our patients. There were multiple secondary endpoints. I think I have this slide here. I wanted to include this sign just on the note of clinical utility. We're not reinventing the wheel here. When other laboratory tests are developed, this is a precedent set for clinical utility and trial design. So this is something that is, for those of us, I'm going to speak about myself here. I really hadn't done a lot of diagnostic studies prior to this, but these pathways are really important for us to understand in the design of these studies. And so just for those of you who don't design diagnostic studies, just know that this is the standard. The inclusion and exclusion criteria, pretty straightforward. Basically, if we suspect that somebody might have leptomeningeal disease, and if they're willing to go on study, sign informed consent, and be tested, they can go on study. The primary endpoint was measured by physician questionnaire. We want to know directly from the doctors treating these patients, was it helpful? We also wanted to know, how was it helpful? So that's different at baseline compared to subsequent follow-ups. So at baseline, we want to understand, were patients already diagnosed for LM, yes or no? If no, did this test help? what's the status? We want to understand, did CNSide contribute to that assessment? Did it inform drug selection? And very similar questions at subsequent visits, but really importantly here, that was really to understand what's the trend, what's happening, and are you using that trend to then manage your patient? So here's some simple answers that we got here. Number one, CNSide helped make clinical decisions in leptomeningeal disease patients. So we had, of all patients in all visits, we had 55 was our N. So basically, remember, we powered this study for a threshold of at least 20% clinical utility, which maybe seems low to some of you, but it's pretty standard. And if you think about tests that we order on a daily basis, CBC, CMPs, et cetera, how often are you really managing and changing your care based on that test? If it were 20%, that's a pretty high number. And so we were really hoping to achieve that. We sort of blew that out of the water. This test was extremely important across the board in helping make decisions here. This is a really simple graph, so I'm not going to read it to you, but it was important not only at baseline, but at subsequent visits. CNSide helped diagnose leptomeningeal disease. Of the patients that went on study, and I apologize because I said 50 and it was 40 patients, but of those patients that went on study, 10 entered study with a suspicion, but unsure whether or not it was leptomeningeal disease. Of those 10 patients, 7 went on to be diagnosed with leptomeningeal disease, and 3 were deemed to be negative. And I really want to especially focus on these 3. For those of us who take care of leptomeningeal disease patients, if you get this test, cytology is negative, and you see 0 cells, the amount of reassurance that we can provide our patients that they don't have leptomeningeal disease and the amount that changes the management is huge. And I know a lot of times when we talk about this test, I've had many conversations with colleagues about this test since being here in Houston, and I feel like this is the topic that gets overlooked the most. We're talking about targets, we're talking about trend, and we're not talking about the huge impact of ruling out leptomeningeal disease. So 3 of these 40 patients were impacted in a really big way from that because it changes your radiation, your treatments, so many things, and potentially in a big way, quality of life. Take home number 3, CNSide helped to evaluate the status of LMD tumor. Again, very straightforward graph. I feel like these are I'm showing you graphs here that I can show my elementary kids here, but there's the idea is that this is really straightforward with clarity to us, that CNSide helped to decide that there was no change, helped to decide that when there was treatment response progression, and there was, of course, a scenario where CNSide didn't help, but definitely a minority. And also, we all know that we need to open doors and windows for our patients in their treatment decision making, and just that there are, in general, a paucity of treatments for our lepto patients. And what was really nice to see is that CNSide identified mutations to use in drug selection. And you're going to hear a little bit more about this tomorrow, so I'm probably going to just use this for a plug. The data that I presented to you today was what we had presented to date at our prior abstract submission. There's some data that I'm not showing you here on purpose because it's embargoed till Sunday, which is when we have our oral presentation during the clinical trial section. This is my shameless plug to have you all come, but just as a spoiler alert, it has to do with this, which is identifying mutations. And this is real huge impact for our patients because, again, if you're opening doors and windows for novel treatments for our patients because of what we're finding in the CSF, it's huge. So please come on Sunday if you're still here and hopefully awake by 10:15. All right, so 4C did meet its primary endpoint. We were able to, help with CNSide, help make clinical decisions, and was impactful in clinical decision making in 91% of the surveys used. It helped inform therapy selection. Sorry, this part got cut off here, but compared to cytology and matched samples, CNSide was more sensitive. I did slide over that slide on purpose just for time's sake because I wanted time for questions. But take my word for it, it was more sensitive. I think you all know that as well. And we're really working to get as much data as we can from this study that had, had to be change hands in its management, but really it's important to all of us who are involved to get this data out to the scientific community so that we can begin using it on a regular basis for our patients. So with that, I'm going to pause, see if there's any questions. I'll kind of moderate any questions that you have, not just for me, but for the whole team here. So does anyone have any questions? Hi. It's a great question, and there's folks here from the company as well, but I'll comment to say that there's a CLIA lab that we've been working with, and we're hoping for early Q1 of 2025. Yes? Okay, great. Yeah. Hey.
Question for Dr. Brenner, and that's whether the dose delivered to the lower spine was as great as that to the upper spine and the cranial compartment. I can imagine that if you needed to, you could do a bit of a ventriculo-lumbar perfusion to help deliver dose downward.
Yeah, that's actually a great question. No, it wasn't as high. We were about at 150 gray in the spine. It seemed relatively uniform in the spine, and I think we need to go back and look at the imaging a little bit closer to look at the thecal sac, down and lower in the spine, and compare that. Some of our sites have better quality SPECT CT imaging than others. Stanford is coming on board soon, and they have a very high resolution scanner that we don't have access to. So that will help us with better spinal dosimetry. But yeah, that's an interesting thought about whether if you have specifically patients with cauda equina involvement, that maybe those would be better served rather than intraventricular delivery, but with a lumbar delivery. Theoretically, there's no reason you couldn't. You get CSF flow from a lumbar puncture, you can inject directly into that like you would methotrexate.
Any other thoughts or questions? Yeah, go ahead.
More an observation rather than a question. That's that the doses you're achieving are incredibly high. Investigational treatments often err on the low side, but you're going way high, and I'm puzzled how this can be safe. I assume you're following patients through their whole survival.
Yeah.
I'd especially be concerned about the spinal cord. 2 millimeters penetration into spinal cord involves a lot of critical tissue.
Right, you and the FDA are on the same page. I think there's a big difference in radionuclide therapy and external beam. And even when we were doing GBM and we were describing, we had some patients that got over 700 gray to the tumor, and we didn't see significant necrosis, radiation necrosis outside of the tumor field. We are not seeing anything that is considered a safety signal. We actually, because of those concerns, had 2 different requirements that are going away in the subsequent trial because we now have adequate safety according to the FDA. One of them was we required 90 days between successive cohorts for neurologic symptoms, not just the typical 30 days of a dose escalation trial. We have a number of patients that are now 3 years out, beyond 1 year for sure. And we're not seeing any, significant neurological injury to suggest that it is unsafe. And then on top of that, we excluded patients who had prior radiation to the spinal cord or whole brain radiation. But since we didn't see anything, the FDA, after this, going into the multi-dose, felt comfortable with removing that exclusion criteria.
And I'm going to maybe have Dr. Yang weigh in as our resident rad-onc here.
Yeah, I think I think radiation effect, I think what you're alluding to tend to be late effects. So data, obviously these patients are still being followed, and we'll have more data moving forward. As somebody who essentially only use external beam, I think the fractionation approach is, from the radiobiologics perspective, it makes more sense. So I'm excited to see that the next phase of development include, dividing up the dose over time.
So I have a question for Dr. Yang as well. Let's imagine we gave a dose, a standard dose, and just by bad luck, there was a block in the flow, say in the cervical spine, and all that drug stayed in the ventricular system or the intracranial cavity, how bad would that be?
Do you want to take that?
It was for you. See, I'll make a comment and then I'll turn it over to Jonathan. But you know, when we designed the protocol, we did not know that this would redistribute. So the first thing we did is our doses were such that we knew that they would be safe doses to the ventricular system if it did not clear. And every one of these patients has a flow study before we proceed with dosing. We have yet to see any cases, and we even had some patients who have shunts, and as long as their shunts can be turned off for 24 hours with redistribution on the flow, they're still allowed to proceed, and we haven't had any issues. So you can answer further, I think.
Yeah, no, I think that's a very important part of the phase 1 study in a sense of understanding the flow and making sure as a safeguard. In reality, I think as many of us take care of these patients, it is hard to balance how to obtain that while trying to get them on therapy quickly, right? So I think that there's a very important component of patient selection here as well. But as Dr. Brenner mentioned, the study is designed and has been done with a mandatory flow study to ensure that it can be distributed.
Yeah, I'm just lazy, and the pictures are really beautiful when you administer the drug, the ones you showed. So I was like, oh, maybe that could be the flow study, and then, you know, if it didn't get through, it wouldn't be such a terrible thing. Then we would know for the next dose.
Great point. We ran out of diagnostic agent. There was a problem, and we gave 1 millicurie dose, and we were able to do a flow study with a 1 millicurie dose. So you can use the same therapeutic agent as a diagnostic agent in a lower dose, and the imaging comes out just beautiful.
Oh, that's a great idea.
You presented that the median overall survival for the study was 9 months. Was that systemic disease or non-CNS progression, or was it from the CNS?
On the rhenium study, that was overall survival. You know, in terms of how the patients progressed, I'd say most of these patients succumbed to neurologic disease in terms of the mortality.
But the OS was just overall survival. I say this because one of my patients on the study died of her systemic disease while on this. So it does happen, but to Dr. Brenner's point, as you know, the driver ends up typically being LM. So what I can tell you is from even a regulatory perspective, the FDA, I think, typically accepts OS as an endpoint for the treatment of leptomeningeal disease, knowing that our diagnostics aren't, our current standard of care diagnostics are not necessarily up to par to have response rate be the primary.
So do you feel like the CSF, there's recurrence of disease, or just progression because these patients are so sick at the time of presentation and subsequent?
Yeah, this is that's a technically challenging part of designing a trial for leptomeningeal disease, and I applaud Dr. Yang for being able to do it with proton, because these patients can show up, look great, and then you take 3 or 4 weeks to get them on study, and they come back with encephalopathy, cranial nerve deficits, and you're sitting there, do I treat them or do I not? And so I think we're going to have to be very careful of how we do these things. You don't want to be selecting for the perfect patient. That's not clinically relevant. But at the same time, you have to give the drug a chance. And this has a half-life of 90 hours, and I think when we see responses, we're seeing them at about 3 to 4 weeks for whatever reason.
Thank you.
Thank you, everybody.
Is there any other questions? Oh, great. Oh, for the CN side? Oh, you can send 4 to 6 cc's in that too. All right, thank you all.